Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology, searching for applications and processes that will hopefully bring productivity and efficiency to healthcare delivery. I'm really pleased my guest today is Pavani Munjuluri, who is the co-founder and COO of Cognitive Health Technologies. Pavani, welcome to the show.
Thank you so much, Jim. I appreciate this time. I've always been on the other side listening to you, and I'm very excited to be on this side chatting with you.
Well, thank you. I'm looking forward to this, especially as I did a little research into cognitive health. I know that you developed this platform. It's called ICANN, which stands for Integrated Cognitive Automation Neuron platform, and it employs both aspects of machine learning and, of course, artificial intelligence that has functionality designed specifically for healthcare. And I know one thing in healthcare, whether it's the front office or the back office, there are numerous repetitive tasks that can be automated. That frees up the staff and to focus on really true value-added work. So this whole idea of intelligent process automation in healthcare, can you tell us a little bit about the trajectory of IPA in healthcare?
Sure, Jim. And again, thanks for the time. I have been in healthcare for many, many years. And one of the things which we've always tried to work is how do we kind of get around this operational inefficiencies, which seems to be the news every day within the space, to move all the dollars to as much as possible to the patient care and keep your administrative costs to the lowest possible, increase your cash flows. And we've seen healthcare as being slower for our inherent, the way our market is so unique with three drivers of the payers, providers, and patients together in the triangle, as well as inherent risk averseness, which we have. We've been slow in taking on new technologies, new initiatives, whereas some of the other industries, as we've seen, have been working on this for a few years now. But I think this is the right time for healthcare to get into the space of IPA, which is the intelligent process automation, which is a little more than the RPA, which is the robotic process automation. And the focus has all been for the healthcare has been to look at areas of care delivery or risk contracts, etc. But I think now is the time where you're able to focus on bringing some of these technologies which have seen success stories in the other industries and make it work for healthcare.
One of the things I'd be interested to hear from you is some of the very specific applications in healthcare. What are some of these repetitive administrative tasks that can be handled by IPA? What are you finding?
So as at the beginning of the conversations, as you're talking about the front office and the back office, and there's also the concept of middle office where you're trying to do a lot of things. Due to the public-private partnership delivery model within the healthcare space, we have a lot of workflows and processes which are very complex. And due to these multiple entities coming in and providing various technology and consulting solutions, we have a lot of point solutions across the system, both on the health plan side and the provider side. And it's a very cumbersome web of applications to complete a transaction, going from sometimes up to 15 to 20 applications and systems to grab the information and complete the process. I think this is where the nuts and bolts of the IPA comes in, where you're looking at the entire all the workflows and operations on the revenue cycle side or the IT operations, including your enterprise functions like HR and finance and recruiting, supply chain has been leveraging a lot of this technologies to the new world where we are, the post-COVID world, where they're seeing the traditional ways of working on supply chain as being a support function, no more work. You need to bring them into the foray along with the clinical and the financials to be able to drive some of these efficiencies. So areas where you see multiple applications, a lot of data moving between different systems, mostly siloed and not enough integrations. So instead of trying to build all of this around, think of IPA as a wraparound around these existing enterprise applications to deliver the next level of efficiencies.
Before we jump to the details of some of these applications, I'm curious, just on a personal level, how did you get involved with this? What drew you to this, trying to solve this problem in healthcare?
Sure. So my you wouldn't believe if I said this, but my education, I did my major in architecture growing up in India, and then I did my master's in business administration. And one of those fluke opportunities which I got to work with a mid-sized small company based out of North India, where outsourcing component, the BP or the business process outsourcing, was just taken off. And I had the opportunity to work with various aspects of players within healthcare, where the initial days of medical transcription, billing, and I figured, it was fascinating for me to learn that so many components within the entire space are struggling to outsource, if you will, to reduce costs due to tremendous pressures on keeping their costs down and providing care and the nuances around all these complexities. So that was my very initial exposure to looking at all these processes from outside in perspective. Fast forward a few years ago, when we've been traveling to US to meet the clients, etc. Been in the conversations with the C-suite execs for the last many years, and the same message over and over: how can I improve my care? How can I reduce my costs? And people are trying to do various different aspects to this. My most recent for me was I was working for a New York-based startup company which was trying to leverage real-world evidence-based data to drive treatment patterns for oncology patients. And the initial project, the initiative included a health plan and a health system and the startup company. While both the payer and the provider had the right intentions to make this work for the end consumer, which is the patient, their systems were so cumbersome for them to transact the data and actually make the entire model work was unbelievable. I could not believe that both sides of the aisles are sitting at the table, but their systems are unable to work and make this work and make this a reality for the patient, where this could have saved or increased their lifespan or their possible probabilities of having an effective treatment. Which is where we kind of looked at what can I do beyond what is there in the market, and all these research reports on how the automation is working for the banking, the consumer industries, the companies like Bank of America, or in retail has been leading the P&Gs of the world, how they're taking all of these extremely intensive consumer-driven data and building automation around that and taking away the costs and using all of that dollars for something else. So why can't we not use the similar technology, which has seemed to have much more matured in the last 4 or 5 years? Why not bring that to the healthcare transactions, healthcare operations, and make a difference in this space? So that's been our moonshot, if you will, our motto on how we got into this, Jim.
I think it's fascinating. You started with a degree in architecture because you're still building things.
You know what? That's exactly what I tell my parents, that from building physical buildings to network architecture to actually building processes and things like the new technology in this space right now. Let
me ask you some questions about some of these. I worked for a while at a large clinical practice. And let me talk about bring up some of the repetitive tasks that took a lot of time. Mm-hmm. And you can let me know if these are the types of tasks we're talking about automating. One had to be involved with just to verification of somebody's insurance. People would have to make phone calls and check and things like that. Is that one of the types of things that can be automated?
Yeah, so even before the human, and I just want to also tell you something what I learned. The verification of insurance happens at 4 or 5 different times throughout the process. So when I as a patient come in, the registration front desk checks my verification. When I go and meet the physician, the billing office checks my verification. When I have a treatment or any kind of procedure or anything else recommended, the prior auth team checks my verification. So my verification is checked by multiple different entities within the organization, and there's an extent to which you can go check with the insurance company on their web portal if they have, or there are multiple other ways. This is a great example you bring in to leverage IPA, where we are providing this platform which goes in and crawls or looks at the website of the payers and does all these steps which are required, like sending an email or going to the website and into their portal and checking and bringing back the information, and make that information available for all these 3 or 4 different entities which are checking my verification. The thing where we still need to go to the next frontier, where you can actually make a call, is where we are still working on, where you still have those chat bots, which you may have seen in multiple other websites, where you go for a customer experience, but actually making a phone call is away for the bots yet. But till that moment in time where you can get all the information by interfacing with systems, you can bring in IPA.
What I saw, and thanks for explaining, because there are so many touch points for insurance verification, and again, authorization for specific procedures, and much less just for the actual visit itself. Often just going to the website itself, if you don't have to make a phone call, the information there may not be updated regularly. So that whole area, and so that really is the whole area that kind of touches on revenue cycle. I know that you work with the Yale-New Haven Health System on their implementation of IPA, especially in the revenue cycle. Can you share what specific processes they've moved to with IPA and what results they're seeing?
Absolutely, Jim. And so when we met with Yale, I think we met with the Yale-New Haven Health with a 13-page PowerPoint slide. It was a concept. We were looking to work with, and we approached Yale, and they just jumped right on and say, hey, we would like to experiment on this, and they have been supportive since then. So we kind of went, as you rightly said, the verification of insurance and the problems which we thought would be the most value, or the candidates for IPA. We had a list of use cases to give them, and so we can work with them on them collaboratively, joint, and develop that. They came back and said, hey, why don't you do something super non-sexy? We don't want this to be something which is talked enough in the market. Let's just go to the real back end of revenue cycle and see if your IPA can help us there, because the verification looks like we understand the concept that might work, but I want to see if this works at the real back end, which is the cash reconciliation and posting, which is non-glamorous work. There's a lot of people. You have different systems. You're getting information from the banks. You're getting information from the payers, the remits. Your systems, your EMR systems and your billing systems are connected to some of these, and they also generate reports of how much cash and money you got. Can your IPA look at this, reconcile this, consolidate this, and give us a daily reconciliation of all of this money is coming in, so my reporting to my CFO office is much more streamlined. That's the very first use case we did for them, and that has been up and running for over a period of an year now, and we're doing much more things there. We're connecting to the CFO's office and also onto the accounting side to be able to do more with the data intake we are doing. The second one where we're doing is leveraging some of the artificial intelligence or the natural language processing to not only read the documents, the thousands of correspondence which you receive on a monthly basis, to be able to do the right kind of data extraction and push it into this relevant queues where where the decisions and the action can be done in a very, very timely manner, and we are avoiding any runovers or backlogs on the correspondence process. So that's been a phenomenal go live a few months ago, and that's been another great use case for IPA. The last and third one I want to talk, there are many working and many in development right now, but the last one which I would like to share with you is, again, the non-glamorous side of things, which people don't really see that much, which is the entire test creation. Every time all these applications are going in upgrades, getting a new module, etc., there's a lot of testing required, and which means you need to create a bunch of test patients within the system to be able to do this test creation, which is, again, none of the testing engineers would like to do this. It's just a manual, tedious, mundane process where you're spending 10 to 15 minutes creating each individual patient. Come in RPA, we are able to take that entire manual task away from the testing team. They are actually able to spend their time looking at the utilization of the actual test scripts and test cases than creating these individual patients. So they kind of save a lot of money doing this, and they're available to their other team members and engaging in more meaningful discussions when they do these upgrades. They kind of talk about the cash posting use case is saved about 80% of their manual work efforts, and for the others, the results are coming in, and there are different ways they are capturing the results than just by the staff saving.
Yeah, I'm curious, Pavani. At Cognitive Health Technology, who are your clients? Are they large health systems? Are they large practices? Are they insurance companies? Who are your customers?
So our customers are all the three you've mentioned, Jim. I think that's one of our vision is, right, just the example you gave where talking about the insurance verification. When you go to the payer side, the information may not be updated. So imagine a situation where you have an ICANN on the other side of the house, on the payer side, where it's constantly grabbing the information from their system and updating the portal real time versus, depending on either some kind of interfaces or human interventions or a human trigger for doing that. So our vision is to be on the either side of the house where the ICANN from the provider side is interacting with the ICANN on the payer side to seamlessly conclude the process with least bit of human intervention and just flag the exceptions or the complicated cases which are not a straightforward decision making but actually need a human to get involved in.
From what you've seen so far, I'm sure there have been some best practices learned and, certainly lessons learned. What are some of those if organization is considering IPA? Where should they start and what should they examine? What's the path forward if they're starting to think about this technology?
Sure, Jim, and as you know, this is, I don't even have to say this, one size doesn't fit all, right? Every health system says they are different, and like each individual, all of us would say we are different. So one size doesn't fit all. It depends on the journey where they are. We have seen the wide array of conversations where a health system or a payer is sophisticated enough to have a lot of their systems working at an optimized level, and then they consider wrapping around the IPA to do the next mile. And on the extreme end, you have a lot of homegrown applications which are very heavy and they suck in a lot of money for the maintenance, and that's another area where the IPA can take away all the pain and just work on the system. So the entire range. But if I need to kind of look at a few pointers, I think the first and foremost would be the buy-in from the C-suite as well as the operations team. While the C-suite team would say, hey, this is a cool technology, I want to leverage this and I want to take the benefit and advantage of the efficiencies and labor savings on this. The operations team, which is where the most of the business rules lie, sometimes documented, sometimes just in their minds, is the team which we need to get the buy-in from to get this going. If we don't have all the buy-in from top to end, it takes a much longer implementation cycle. The second one I would say is to have a broader view or an enterprise-wide strategy. Do not look at IPA as just one shot in the arm to fix one problem in one use case in one process, but have a more broader viewpoint to say, hey, if I'm leveraging an IP or an automation technology, how can I think of this across my enterprise? Because that's where the scale and the returns would actually come in, and the benefits would start showing up much quicker. The third one I would say is have clear expectations of leveraging the automation. Every process is different. At some places, it's a labor saving. Some places, it's an efficiency. Some places, it's a increased cash flow. So to have clear expectations of what I want this automation to do is important, and that drives the design and the functionality of the automation.
You know, I used to be involved in EHR implementations, and something you mentioned, the concept of you want buy-in. You have to have buy-in because you're affecting change, and you want people to lean into that change. And so frequently it seems like a good start is to create some functionality that everybody can immediately see value and say, oh, I like that. That's a good thing. It's that low-hanging fruit that you kind of go after. And so would that often be in the area of revenue cycle and insurance verification? What do you go after first to prove and really get that buy-in?
You're absolutely right, Jim, and thanks for elaborating on that. You need to get one success story in, something which they can look and feel good about what they have accomplished. And yes, so initial use cases could be in the revenue cycle. So we do have a library of use cases, and as I said, each health system has a different pain area. Some do not necessarily look at cash posting as a pain area. Some look as a correspondence as a pain area, and some look at verification as a pain area, right? So I think we have the list of library of use cases which can be deployed depending on where do they see the success. And the other thing also to consider is, as you have an enterprise strategy and want to give the users something which is a success, whoever is the department head driving, they need to be the believer in this. So that's one of the other things. The process may be very conducive for an IPA, but the director whoever is the head may or may not be a believer. So it's going to be an uphill change management task, as you rightly said. So any of these processes, whether it's a patient demographic capture, whether it's verification, whether it's correspondence, whether it's cash reconciliation, whether it's patient creation, all of this could be easily deployed from our library of use cases and proven the concept and the technology to the team.
We only have about 2 or 3 more minutes. I can't believe how the time has rushed past us here, but I've got to get your thoughts on looking at the crystal ball and what predictions you may have for the future of IPA in healthcare. Where are we headed from here?
If you allow me a Star Wars reference, I think we're all going the Jedi way. That's what I would say. I think this is one of those changes. I don't see this as a flash in the pan. I don't see this another thing which is just coming and going. I see this as taking ground, taking roots, and expanding as we go ahead from it. This is a phenomenal technology where I don't want to be spending my time in the day looking at day in and out on different screens and clicking and finishing my day by saying, hey, I did 1,000 transactions. I want to be able to actually do meaningful transactions where I've actually felt I've collected $1,000 from a claim which has been stuck at an insurance company, or created a new workflow which has changed the way my team works. So I want to be able to, when I come into work, I don't want to do transactions. I want to be able to provide value. And I think leveraging this IPA, there are so many different options out there for health systems to consider, whether they do their own in-house, whether they engage with a vendor, whether they buy some licenses. This is going to change fundamentally how workforce exists. It's going to be a combination of humans and digital workforce, as we are calling it right now. And that's only going to go much further than what we have seen or anybody has imagined. That will also put additional emphasis on all the way the clinicians and the physicians and the nurses and all those extremely skilled people do their job. So we are kind of helping them free up all of their time so they can do more meaningful work and provide more value to the overall system.
Finally, how can our listeners learn more about the work that's being done at Cognitive Health, and what's the best way to contact for more information?
Thank you for this, Jim. Yeah, so cognitivehealthit.com is our website. There is a contact us and info links within the page. We have all the information, case studies, how our system works on our website. So please do jump in, and we have our updates on LinkedIn as well. So that'll be the way for the listeners to learn more about us.
Great. Thank you very much. And thanks to our audience for joining us today on this episode of the Tate Chronicles. I offer a special salute to my guest, Pavani Munjuluri of Cognitive Health. Pavani, thanks for coming aboard today.
Thank you so much. It was a pleasure talking to you, and you have a great day.
Well, thank you. And I really look forward to, I've learned a lot today about IPA, and I appreciate your time. And I'll be paying more attention to it in the months and years ahead, because there's so many repetitive tasks out there that can be automated. You can find more information on this show's program page at healthcarenowradio.com. And until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.